Czyli to ja ode mnie tyle i to tradycyjnie pani doktor Bożena Waskiewicz, nasza prezes, jeśli można zacząć. Pani doktor, sekundkę, ja panią dam na spotlight. Już teraz można mówić.
Bardzo serdecznie witam wszystkich na naszym kolejnym zebraniu naukowym. Aż szczególnie właśnie witam naszych prelegentów, doktora Teodora Goroszeniuka i doktora Andrzeja Krola, którzy nam powiedzą właśnie o różnych aspektach bólu i tak jak właśnie było na ogłoszeniach. Także to będzie kolejny bardzo ciekawy ranek. Choć niektórzy narzekali, że to za wcześnie w niedzielę rano, ale przyjdzie lato, będzie nam łatwiej wstać. A to już jest taka nasza tradycja, że zawsze mamy. I miejmy nadzieję, że może już na jesieni wrócimy do Instytutu Sikorskiego i będziemy mogli mieć tak jak zawsze spotkania. Natomiast a couple of words in English to our non-Polish speaking friends who have joined us. I know particularly Kieran Wazir, who is helping our two lecturers organize their presentation. Thank you very much and welcome. Więc bardzo serdecznie jeszcze raz wszystkich witam i proszę, Tomku, zaczniemy już prezentację.
Dobrze, tak, Andrzej, jakbyś mógł zaszerować teraz swój screen.
Okay, to ja tutaj idę na ten share screen. Okay, share sound is there. I spróbujemy.
Dobrze, i możesz wcisnąć pierwsze przyjrzał, czyli wszystko działa, wygląda na to.
Sorry. Coś tutaj. O. Teraz wszystko działa. Teodor?
Jestem gotowy z gongiem, jestem jak najbardziej.
No to wal w ten
Dziękuję
gong.
bardzo. Nie widzę siebie, ale w takim razie, proszę Państwa, zaczynamy. Dziękujemy bardzo za przybycie, dziękujemy. Chcemy zacząć dźwiękiem naszego ukochanego gongu, który jest takim ważnym elementem naszego London Pain Forum. Ja to później z Andrzejem wyjaśnimy dlaczego. W każdym razie rozpoczynamy naszą prezentację z dźwiękiem gongu. Ops. Dziękuję, Andrzej. Ja nie widzę siebie, widzę tylko slajdy. Czy to jest tak miało być?
Tak.
Tak?
Tak, jakby mówicie i slajdy są widoczne przede wszystkim, każdy ma rząd okienek na górze obok slajdów, na którym może was zobaczyć małe miniaturki was mówiących.
Ale ja nie widzę siebie.
Okej, ale jesteś, to dlatego
Ale
że masz na górze.
słyszymy cię, Teodor, i to jest najważniejsze.
Rozumiem. W każdym razie witamy wszystkich kolegów, witamy uczestników. Jest to na naszym kolejnym spotkaniu towarzystwa porannym. Chcieliśmy, żeby to było w ognisku, żeby to było w instytucie. Niefortunnie jesteśmy na spotkaniu elektronicznym, no ale tak jest i mam nadzieję, że w przyszłym roku to wszystko się zmieni. Witam również drogich kolegów z Polski, którzy się połączyli z nami elektronicznie. Wielką przyjemnością jest dla mnie współpracować z Andrzejem Królem i z Kiranem Wazirem. Przeszliśmy długą drogę przez ostatnie kilkanaście lat i ta droga nie przez mękę, tylko przez ból, zaprezentujemy nasze edukacyjne wysiłki, żeby zmienić świat bólowy na troszeczkę lepszy. Także I would like to say big thank you to Kiran Wazir, our third musketeer. Thank you, Kiran. Over the years, we cooperated. Without Kiran, nothing will happen. And from the beginning, we were together and we created few organizations. And this is just absolutely great pleasure to work with you over the years, and thank you very much indeed. Dziękujemy, Kiran, very much. Nasza prezentacja nie jest naukowa ściśle, jest to prezentacja w pewnym sensie o naszej edukacji, którą podjęliśmy kilkanaście lat temu i w dalszym ciągu kontynuujemy. Chciałbym przedstawić mojego serdecznego przyjaciela, kolegę, doktora Andrzeja Króla, który jest konsultantem, anestezjologiem i zajmuje się medycyną bólu, pracuje w St. George's Hospital, ale nie tylko, również pracuje i prowadzi klinikę bólu w swoim rodzinnym Słupsku i było zawsze wielką przyjemnością współpracować z Andrzejem. Andrzej jest światowym ekspertem w sprawie ultrasonografii dla regionalnej anestezji, ale również dla medycyny bólu. Także Andrzeju, w twoje ręce, przedstawiaj mnie.
So thank you very much for your invitation. It's a great pleasure to be here and share our experience. So I'm very proud to work with Teodor for so many years. He has been my mentor, and we've been our road through pain for the more than 15 years. And together with Kiran, we think we're very proud of ourselves, so we want to show off. And we think we made some creation and in the various aspects, and we're going to take you through this. So with no more ado, I will just move to the next slide. And as Tomek said, there will be certificates. So we have our disclosure. So our education has been for non-profit. So we haven't got any honorarium for our activity over the 15 years. But Theo wants to say that he's a shareholder of his Remedius company. It's a neuromodulation startup company, but this is his creation, and he was advocated. So he kindly introduced me as an expert in ultrasound, but he's an expert in peripheral neuromodulation. This is what he has been doing for many years. And of course, Kiran ran his own company, helping us to go through all this administration organization issue. And for this presentation, I have nothing to declare. So we quickly go through what we're going to talk about. So we've been through the introduction already, but we start a bit of the definition of pain. So we understand that you are not the pain physician, and we explain where we are standing in the pain concept. And then we go through our activity in pain management, not in a chronological order, but more in the event order. So we start with our International Traveling Pain Symposium. Then we will go through our meetings we organize in Poland, and then London Pain Forum Black Tie meetings, London Pain Forum Winter Pain Symposium, our international connection with Serbia, the Netherlands, Ukraine, and London workshops in peripheral neuromodulation, ultrasound. And then at the end, Theo will tell you a little bit more about neuromodulation. So when we start with just to remind you about the definition of pain. In 1974, an International Association for the Study of Pain has been created by John Bonica from Seattle and his colleagues in Europe. And there was the definition of pain, which was recently revised. The pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So definition seems to be very complicated. As a pain, it is, as you will see. And we are specializing both in chronic pain, which has been recognized as pain that persists past normal healing time and hence lacks the acute warning function of physiological nociception. Usually pain is regarded as chronic when it lasts or recurs for more than 3 to 6 months. So we rarely see in our chronic pain clinic patient who suffering from pain for less than 6 months. This is all done by you guys in the community, as most of you are GPs. So next slide, you can say is for the purist of the slides, is a bit messy, but this is a bit deliberate because we want to show how complex is the patient with chronic pain. We have a multimodal approach to pain management. So you may apply one module or two of all of them at the same time or in a different order. But the problem here is that you've been personally biased. So if you're physiotherapist, you will be approaching your physiotherapy. If you are a psychologist, you will be looking for the psychological problem. If you are like us, interventional, you will be thinking about doing the intervention. And it's not necessary the right for the patient, but this is just what is your expertise. So this is why it's a lot of bias, and this is why it has to be, we have this multidisciplinary approach and MDT meetings to get the right treatment for the right patient. For example, if you think about the pharmacotherapy, you have these simple painkillers like paracetamol, non-steroidal, weak opioids like codeine, tramadol, tapentadol, but we talk about the strong opioids, all this buprenorphine, morphine, fentanyl, oxycodone. And then in the news, the one day you read about the wonderful drug which cure pain, and the other day you will read about the other drug which is which will kill you. And this is very, very confusing. And nowadays you will be hearing opioids are very bad for chronic pain, but cannabis are the future, the solution. But if you look through this, over the 100 years, there's not much change. And how we improve, this is the syrup Nakasher, which contains some cannabis, alcohol, chloroform, and morphine. So have we made any progress with our pharmacology? So where we stand, it's the pain intervention on the right corner. And so my specialty is ultrasound and safety intervention, and Teodor is neuromodulation. But if you talk about the neuromodulation, you not only think about pain, but there's some symptoms control. So neuromodulation has been used to treat epilepsy, to treat overactive bladder, to treat obesity. So it's a lot of application for neuromodulation. So that's about the introduction about where we stand and where the pain is. And now Theo will tell you where he is coming from.
Thank you, Andrzej. It is absolutely perfect. And I have been working in Guy's and St. Thomas's for many years. And this is my two beloved hospitals. And Guy's Hospital, everybody probably know about it, was founded by Sir Thomas Guy. Unfortunately, he died before the hospital was open. Surprise, surprise, but St. Thomas's Hospital was situated on a sadok in St. Thomas Street. And on the next slide, I will show you where is the remains of the St. Thomas Hospital in the area. Sir, no, not yet. Okay, there. Sir Thomas Guy is buried in a crypt in a little chapel at the entrance to the Guy's Hospital. I have to say that I'm from the many people which I could select and choose and to tell you a few words about it. I'm biased. I'm neuromodulator and I'm obsessed about medical electricity, and I selected Golding Barrett. Golding Barrett was the first head of the first electricity department. We believe, hope that is the case, still checking electricity department at Guy's Hospital. He was a great young person, died at age 40. However, I'm just now finishing a little paper about Tesla and Golding Barrett, and hopefully to be published shortly. Next one, please. And another big place of mine is St. Thomas Hospital, which has been described, as you can see, probably about in 13th century and named after Sir Thomas Becket. And position remains of the St. Thomas's Hospital is the old operating theater, the just opposite Guy's Hospital, St. Thomas Street. If you have the time, perhaps that is worth the trip, and to see this beautiful piece of the old operating theater over there. Current position of the St. Thomas is from 1871. This was a big investment opposite Parliament, and it changed the sort of probably at the time that was the largest hospital in London, and in a prestigious position opposite Parliament. Next one.
Okay, next one. So I'm coming in
your hands.
And so I tell you about the St. George's Hospital, which was founded in 1773 in Hyde Park Corner. Now we have a Lanesborough Hotel over there, and we moved to premises in Tooting in the 80s. I work closely with anatomy department and doing the teaching there and the research. So if you think about the Gray's Anatomy, the series, the American series, actually Henry Gray was an anatomist at St. George's, and then with his colleagues he wrote this book about human anatomy. The other famous will be John Hunter, if you are a surgeon, so you know about Hunter Canal, our adductor canal, but most at the moment popular could be the Edward Jenner, because he is named as the founder of the modern immunology, and he developed the first chickenpox vaccine, following examples from Turkey and other countries, and introduced this to general practice that was accepted. But personally for me, the greatest hero of St. George's is Dr. Janusz Bernard Liban, who is the most senior, most respected consultant at St. George's, and very active. And I wouldn't have been there without his support and mentoring. So I have a very lucky two mentors in my career, Dr. Goroszeniuk and Dr. Liban, and thank you very much. And when it all started, it started 25 years ago, when I was sponsored by Polish Hospices Fund and visited North Vernon Hospital and Michael Saber House. And you can see Mr. and Mrs. Hunter from Polish Hospices Fund. And this is how I met and heard about Janusz Liban. And then 3 years later, I was a registrar in St. George's rotation. In 2004, I was a pain fellow at St. George's, and I've been consultant there since 2005. And we have been taking example from him and following his lead, because he has been running, you may heard about the doctor's updates, now about 30 years, a conference in French Alps in Val d'Isère, about 500 participants from multidisciplinary meetings, and another one in Algarve in a beautiful location. And this is the conference I try to attend every year with my family. My daughter was growing up with this conference. We came every year, and this is one of my first presentations. So when I had about celiac plexus block.
Jak tam, Jasiu, jak tam twoje eye test wyszło?
And so that's so thank you Bernie for leading us, for your example.
Ale co, dobre masz oczki czy nie?
And now I think Theo will continue about our experience and the first idea of traveling pain symposium.
That's the idea of the education on the move was sitting in our heads for a long time. And as you can see from the logo, this concept of the education in a different location on a train, we believe is absolutely great. And our people who attended always expressed that is just fantastic idea, meeting on a train, continue with the workshops, having the lovely location, and it's just absolutely excellent example. Next slide, Andrzej, please. As you can see that we use the Eurostar, that usually we rented the coach, whole coach. Remember very much, welcome guys in St. Thomas's Traveling Symposium on Eurostar. That's just was, we were together in one place and continue from practically from the first minute of the trip with the ultrasound. You can see the Andrzej Krol in action with his ultrasound machine. You can see that even teaching and learning how to stitch and sutures on a train, which is just was, I think, was a quite achievement. And of course, you can see that another T-shirt of the present, Andrzej and myself, and with the train on our backs. Next one. This is just was the first. I just disagree with the slides which Kieran put it in. We lost our files and we're still trying to retrieve. This was the first little trip to the Lille, and was the first symposium. We call this guys in St. Thomas's Pain Management Eurostar Traveling Symposium. Next one, please. We gained experience, and the next trip was to Bruges, and our head speaker, invited speaker, was famous Professor Nadi Hakim. And in beautiful Bruges was a great success. We gained a lot of strength, and we felt that this is a great occasion to put education on a move. And we, next one, please. And the great third symposium was in Avignon. This was just absolutely, from the scientific point of view, from the location point of view, this was Joe Azopardi, if you're watching, remember you have been playing the piano till 3 o'clock in the morning in Hotel Europe, and we discover your talents, not only the scientific talents, but also the absolutely fantastic skill as a pianist. Next one, please. We moved further to Appetite, high up. We moved to the Loire Valley. This was, from scientific point of view, another great success with so many prominent speakers from all over the world. And location was absolutely another great location. Next one, please. Then the decision we made, Kieran, Andrzej, and myself, to move to Champagne, and thus we rented the Mercier, most popular champagne in France, that we having lectures in a cave down to the bottom, and we decided not to go to the range but to Epernay, and this was a great decision. Another scientific success and location also. But next one, please. Andrzej has kindly presented his sacroiliac joint, which we have a joint interest with Champagne, and thank you, Andrzej, for showing this. Right, now we'll move to the serious politics. There was a Maastricht Treaty 2011, not treaty, but our meeting in the caves of the Chateau Nercan. And you can see that Theo and Andrzej shaking hands on the forefront of the Maastricht Treaty signatures in a cave. Was, from scientific point of view, was absolutely success. You can see to the left the president of the International Neuromodulation Society, Professor Robert Levy from Florida, and below there's a photo of the probably 1, 2, 3, 6 presidents, and Theo standing on the left. That was just absolutely splendid, splendid occasion. Next one, please. Right, we didn't stop and to organize this year after year, and this was the great effort. And again, thank you, Kieran, for taking effort, a lot of preparation, a lot of things, and that we moved to the Lake Annecy. And I can simply say there's another and our success from the scientific and location point of view. And then the little Struct disaster happened. We went to Scotland, Andrzej, Kieran, myself, and we were trying to locate some suitable chateau and castle for our location, and we selected the excellent hotel, which unfortunately burned down a few weeks after our departure, and we have didn't play any part in it. But this was our last meeting, and we are planning to return to the traveling symposium, Education on the Move, with the plans to go to Madrid, plans to go to Rome, and at the present, due to the climate, this is not possible.
Okay, I think now we are traveling to Poland, because as you discovered, this a little bit of science, a lot of traveling, geography, but also our cultural heritage will come up. So we will, and for the next couple of minutes, I will talk about experience in Poland, our meetings which started in 2009 with Białystok and Gdańsk and Warszawa when we did our last meeting. So it's all started in Białowieża. Our first workshops, and then foundation of interventional section of our Polish Pain Society, and this was thanks for our local colleagues, Dr. Nierodziński and Krzysiu Piekarewicz, and you can see us standing in front of the Branicki Pałac, where anatomy department is located, and then from the left you can see Teodor, Dr. Piotr Buczkowski, who is a consultant in pain medicine and anesthesia and in Derby, originally from Gdańsk, myself, Kieran, and Dr. Wiesław Błach, who is the orthopedic surgeon from Szczecin, who enthusiastically joined us. And you can see here under this Żubrs, there's a Dr. Basiński Andrzej from Gdańsk, and Dr. Rykowski, who used to work in Robert, Sweden, and they all supported us, and this is all creation of our interventional section. We looked for the inspiration and for blessing. So our meetings and our educational events were associated with some cultural experience, and we were looking for the blessing under Ostra Brama in Wilno. And you can see us here. So that's Dr. Buczkowski and Dr. Joe Azopardi, Maltese Knights, and our colleague from Guy's and St. Thomas's Hospital. We were looking for the meeting with the locals, and also looking for our cultural heritage. So Józef Ignacy Kraszewski, dom, w którym mieszkał Juliusz Słowacki, and you can see at the bottom corner here, so Teodor and Piotr already giving interview for the TV Wrocław about our presence. So we were very media oriented at the time, promoting our activity. So our journey started with our Polish Pain Society and the presidency of Dr. Dobrogowski, and now Dr. Magdalena Kotor-Klemska. We are very grateful for the support from our activity. And just to introduce quickly from the left to right our section chairman. So we started with Dr. Pernak de Gast, and then Professor Basiński took over after Dr. Buczkowski. Then Teodor took it for the term of 3 years. Then myself, our colleague Grzegorz Hura from Bielsko-Biała, and now Darek Koson from Medical University in Warsaw. I think Darek is with us, with Marcin Kowat. So our colleagues are continuing our work. So we're very proud and very happy that this is what we started. It's continued. Just an example of our activity and workshops. So this is one of our workshop setup. Also, there's some talk with Kieran with administration, and a lot of teaching and on the caravans. So our meetings were, you may say, like three layers. One, we usually organize satellite symposium to the Congress, main Congress of Polish Pain Society. And you can see all the faculty, Dr. Rykowski, Joa Zopardi, Tio, myself, Elliot Cranes, Gabor Raj, all the famous names, if you know in the field of pain, that were joining us during this workshops. The other activity was during the Polish Pain Society every other year organized meeting in Zakopane. So we contributed to every year, but also it was associated with some hiking activity. So going to the mountains to Kasprowy Wiehr. If I can tell you the story, then one year Dr. Goroszeniuk and Dr. Rykowski went up to Kasprowy Wiehr, but they lost their way and ended up in Slovakia. So they had to be rescued from across the border. So it did happen. We also were organizing the meetings which standed on its own as associated with the workshops and our interventional and neuromodulation congresses. So this is beautiful Aula Leopoldina in Wrocław when we held our meeting in 2011, and we had a faculty prominence of Professor Samuel Dabi from Middlesbrough, Charles Gauci from Whipps Cross, and other Maltese Knights, Professor Jonathan Richardson, Declan O'Keefe from Ireland, Professor Jose de Andres from Valencia, our former Minister of Health, Maksymowicz, Filip Mavrokardados, Professor Paweł Michalek from Prague, our President, Professor Dobrogowski, Dr. Jerzy Jarosz, Teodor, Elvira Guraj from Center of Oncology in Warsaw, and Teodor and Piotr, and Dr. Sylwester Mordarski, who was our local organizer from Wrocław. I just found out yesterday that he sadly passed away last month. The other event we were very proud was a conference in Torun, in Dwór Artusa, and was supported and under auspices of the president of Torun. And this event was very special as we hosted two guest speakers, Chris Wells, who was at the time president of European Pain Federation, so it's oldest pain federation in Europe, and Professor Jose de Andres, who was at the time president of European Society of Regional Anesthesia. And we discussed about creating the pain exam at the time, and then funny enough, all the presidents walked away, and now we have one European diploma in pain medicine by EFIC, and we have a European diploma of pain medicine by ESTRA, but hopefully in the future, these two exams will just set up the common standards in pain medicine. And this is our last workshops with our colleagues from Warsaw, Marcin Koła, Darek Koson, and Marek Janak. We held in the forensic medicine in Warsaw. It was in 2019. We hope to restart our activity. Maybe this year we organize another one in September, but it all depends on the situation. So this is why it is this broken page. There's a teaching, there's education, hands-on workshop, but also there's a bit of research activity on our side. And I take a credit, I think this ultrasonografia, nowa ożywcza era w anestezji regionalnej, rola ultrasonografii w medycynie bólu, stan aktualny. I think there was the first article in the Polish literature about the ultrasound in pain medicine and regional anesthesia. And this is another one we wrote together with Tio about the peripheral neuromodulation, and a special one with all our colleagues contributed, and especially thanks to Michał But, who put it all together. And this is, I think, the one of the first available in Polish language review of the procedure, interventional pain procedure, and the indication for them. And also we contributed to the few chapters in Medycyna Bólu and the main, the TIC solid book about the pain medicine in Polish language. So we're very, very proud of our contribution. So we created with our workshop for the 15 years, so the centers, because our delegates were coming year by year. They were often the same people. They were learning different procedures. So we just creating the map of the interventional centers using this and up to standard intervention in pain medicine. So this number is growing. This is from 2015, but up to date probably is more and more centers using the high standard intervention in Poland. And also we in both Guy's and St. Thomas's Hospital, we had colleagues visiting for the short fellowship, observership, coming to see and to learn from us. So this is just probably not exhaustive list of them who were coming to us. And a few of them, they wrote an article about their experience at St. George's, and they call it Londyńska Szkoła Leczenia Bólu, czyli relacje St. George's Hospital w kilku odsłonach. And each of them, they wrote a short experience and the personal reflection from what they learned at St. George's. And also one of them was Oleg Ruczkiewicz, young, very enthusiastic doctor who wrote a book about Bolesław Rutkowski, who was the first pioneer of Polish pain medicine and Polish anesthesiologist who came from Great Britain and was teaching and introducing the modern anesthesiology. And Teodor wrote the introduction to the second edition, and Oleg very nicely wrote here. Londyn 1947. Brytyjscy specjaliści uczą młodego polskiego lekarza wojskowego podstaw nowoczesnej anestezjologii. Londyn 2017. St. George's Hospital nowoczesnej anestezjologii uczą Brytyjczyków lekarze z Polski. Specy od pain medicine. Dziękuję bardzo, Olku, za te miłe słowa. I think now is the time to come back to London.
Nie ma takiego miasta Londyn. Jest Lądek Zdrój. Tak.
Londyn, miasto w Anglii.
To co mi pan nic nie mówi?
No mówię pani właśnie.
To przecież ja muszę pójść i poszukać. Zobaczyć, gdzie to jest, cholera
Słuchaj,
jasna.
ukradli tobie paszport.
Nie mogę.
So we are back in London, and here, London Pain Forum now.
Okay, Andrzej, thank you very much indeed. Yes, London Pain Forum, you have seen the gong which we used on the beginning. This is a little another new creation and created in 2009. And as you can see, there is just, we promote intellectual enrichment, support of the pain education through the flow of the new ideas, research, collaboration between medicine, science, and the art. We have the 14 fellows and a lot of supporters, people waiting to join this. Could I have a next slide? Unfortunately, you have not changed this. So could I have a next slide, please? Could I have a next slide? Yes, how this started. Dr. Albin Goroszeniuk, my dear wife, we both went to the 700th anniversary of the Barbers and Surgeons Guild in London. And event was 700 years, yes, very, very nice indeed. And we're sitting in a taxi and Małgosia said, Teo, why you don't organize something like this for pain? Oh, it's 700 years, and that's we are in 2009. And I sat quiet for a few minutes and said, Małgosia, you got it. We're going to organize. Can we return to the slides before, Andrzej? Before? Yes, and I went to work. Met Mr. Wazir and said, Kiran, we have to create the new organization, new something which had not been before. And we did it. we created logo. Logo, as you can see, got 4 components, components of pain. You can see the goblet in the middle. Goblet means pharmacotherapy. You're gonna see the 2 faces. 2 faces mean psychology, talk. You can see the sword, which represent interventions. And you can see that's basically neuromodulation. There's 4 components of pain. I think we are very proud of this logo. This logo is present on our gong, which you're going to see later. Next one. The idea behind to meet and in a pleasant surroundings, discuss the world of medicine, discuss the other things, including politics. Usually the concept is to have the lecture of the 40 minutes of the selected guest speaker, then we have the dinner, and then we have a 2 hours discussion, sometimes very heated, and in a very, very, very pleasant surroundings. Next one. Next one. Yes, that after hard work, we quickly, in a few months, we organized the first London Pain Forum meeting. That was in the Ritz, and the guest speaker was one of the godfathers of the pain medicine, Professor Menno Schleuter from Netherlands, godfather of radio frequency and pulse radio frequency. Next one, please. We returned to the Barbers and Surgeon Guild, and this was when the origin, when the London Pain Forum idea was born, and the guest was famous Hungarian-American Professor Gabor Raj from Texas. Next one. We are not going to show you all meetings, but this is just another example. President of the International Neuromodulation Society, Elliot Crane's guest speaker in an East India club. He is also editor-in-chief of the past editor-in-chief of the Neuromodulation Journal. There's another meeting that one of our founding member of London Pain Forum, Dr. Simon Thompson, also president of the International Neuromodulation Society, Apothecaries Hall in the City of London. Then we move something lighter. We selected one of the best eatery at the Ivy, in Ivy, and guest speaker was our very good friend, Professor Jose de Andres from Valencia. By coincidence, after our meeting, a certain person, Her Majesty the Queen, decided to visit the Ivy as well. This was a few days after our meeting. I don't know if probably there is no connection between our meeting and Her Majesty visiting the Ivy. But anyway, this is just very nice of her to follow our steps. Next one. And on the 20th anniversary or the 20th meeting, we decided to move to the House of Lords. And thank you to Lady Belhaven and Stanton Małgosia and Baroness Caroline Cox. This was organized, and we have our important 20th meeting in House of Lords. Our host and guest speaker was Baroness Caroline Fox. She is extremely active on a front of charities around the world, on forgotten people, and she is very formidable lady, and it was absolutely great pleasure to listen to her achievement in various parts of the world. Our fellows and our guests were able to move through the Parliament and House of Commons and the Lords. Next one, please. And this is a comment from Andrzej, because this is just, you were part of it.
Yeah, I just interrupt because I got lost during this tour, and then I spent about half an hour walking from room to room in the Houses of Parliament. So I learned a few top secrets of the government. So if you want to talk to me in private, I may just share with you some of them.
Okay, and now we are moving to the famous, our famous gong. That the gong was idea which has been developed in Polska and Węgrów by Kruszewski company, and got a engraving of the House of Lords, got our logo presented. That was a gift from myself to our London Pain Forum, and we since then we're keeping this gong with us on every event, and even if we are planning to go shortly to Madrid, which we postpone, or even to Wieliczka this year, I hope, we're going to take our gong with us.
Yeah, thank you for this magnificent present, and Theo, and then gong. This our society may just use as well as an example. This is our last meeting, isn't it?
Yes, this is our last meeting, and of course, that was in our Royal Automobile Club. The Professor Samal Dabi was the guest speaker. Unfortunately, that our plan meetings in 2020 didn't have a place, and we are preparing a meeting for this year, but we don't know what will happen, unfortunately. Okay, another baby. Let's another baby. That's of course following the steps of our great guru, Dr. Janusz Liban. We decided to have the separate meeting from his meeting dedicated to pain. Janusz Liban meetings are running for about 30 years for the great number of participants, about 500, 600, and we decided we need a little niche for pain, and we created a meeting in Teen, London Pain Forum meeting for about 60, 70 participants, and this happened since the January 2013 in Teen. Yes, that is just activity on the fresh air. The concept is very similar to Janusz Liban. The lectures in the morning, then a little break with the fresh air, and the evening lectures, followed by the dinner discussion till the early hours of the morning. Always on medicine, always on pain. And this is Professor Ilias from Vienna, our guest speaker on our first meeting. And this is the program and the faculty. Thank you, Kiran, for making such a lovely programs. And many participants are returning continuously to us every year. We have the guests from all over the world, including New Zealand, Saudi Arabia, Argentina. I'm not talking about Europe, this is just standard, but Australia, United States, Canada, and it's just absolutely great pleasure to talk about pain, and not only at the forum or the podium, but also during intermissions, and even when you're on the top of the mountains, we always exchange our views on the pain medicine. Am I correct, Andrzej? I'm sure that you agree with me.
Absolutely, absolutely. So I think now we're moving to our other London Pain Forum activities. So like off spin, our main track, and then majority of these events was held in the Gordon Museum, opened in 1905. And donation by Robert Gordon. If you have a chance just to go there, it's such a fantastic venue with all this specimen from 17th century, and just going all around, it just gives you the spirit of all days. So Bill is a curator of the museum, And a couple of years ago, I was with my daughter, just pop in, and Bill Kennedy come in and just to have a look. And then my 16-year-old daughter at the time were working with me and just looking at the specimen. So it's a fantastic event, and we were holding lots of meetings over there. Our workshops were held there many times. But the other ones were we were doing at our St. George's Hospital, and there was this regional anesthesia UK ultrasound and pain medicine course together with Ezra, and we were supposed to have a 13 meetings. So the number is pechowy, as we say, because it did not happen in 2020 and did not happen in 2021. We're hoping for 2022. But with my colleague Barry Nichols, as a base of these courses for many years with the international faculty, we published a book about ultrasound-guided intervention in chronic pain management. So what we show, you can have a fun and you can have a bit of science and education as well. This is special history we have when we visited Kyiv in 2010. So there was a fantastic meeting. The host was very generous, and they invited us for dinner. And then, as a result, we missed our train. We ended up on the wrong platform and almost was on the train far east in Siberia. But then we were rescued by our conductress Galina, and she organized the nice compartment for us. And Joe, you remember her well, and she organized a bottle of vodka. So we have a very pleasant journey, overnight train to Lviv. And in Lviv, as you've seen before, we're following the heritage of our naszych wieszczów, pomnik Adama Mickiewicza, and we stayed in the George Hotel and this market, and then Teodor was staying in the special room. We rented a special room for him, the room with the balcony where Jan Kipura was singing. Sing, Teodor. Brunetki,
blondynki. Tak.
And this is the University of Lviv. So we had our fantastic tour over there. There's also meeting far away in Mendoza in Argentina, together with Argentinian and Brazilian Neuromodulation Society. It took place in 2014. So I think this is the farthest in terms of distance meeting we have been involved, but closer with our neighbors in Netherlands. For many years, we have been organizing joint meeting with the Dutch Pain Foundation with Kenneth van Tilburg. So there was a few all related to neuromodulation and intervention. And also since 2014, we have been cooperating with Serbian Pain Society and contributing to the annual meeting, but always looking for some traces of our great people from history. So the Ulica Tadeusza Kościuszki in Belgrade. And now I just hand it over to Theo to tell you a little bit about the neuromodulation, especially the peripheral neuromodulation.
All right, we can say that probably that not many people participating in this symposium are familiar with the medical electricity, and that's a good start to show that most famous Serbian, and the most important inventor in the world history, Tesla. Next one. The neuromodulations as such, use of electricity for pain or for function, for whatever reason, is nothing new. And when you see that Anno Domini 46, Scribonius Largus, he wrote about use of electrical fish, torpedo fish, for treatment of gout and headaches. But what interesting that we think, anyway, this was that this book was written on a way to Londinium, because he was traveling with Emperor Claudius as he's one of the personal physicians. Simply there is a touch of London and a touch of the England in this presentation in this book. I would not, I just simply couldn't resist to show you that 1920s, I just discovered this book, thank you to my antiquarian book friend, bookkeeper friend in Warsaw. He presented me, say, Theo, who can buy this book? Only probably you. Yes, and I did. And you can see that 1920s in Krakow, a stimulation of the heart on the left, and you get a stimulation of the spinal cord externally, stimulation of the eye, stimulation of the knee. Absolutely fascinating, fascinating stuff. And I'm just putting the last few sentences to the report, hopefully to be published in a neuromodulation about this book. Right, this is just a sort of a basic thing to remind you. We're talking the peripheral neuromodulation. We are not talking about the brain stimulation. We are not talking the spinal cord stimulation. We're talking about the peripheral one. And delivery components are so-called non-invasive. External neuromodulation, there are numbers of the different branches, different facets. Percutaneous, where the needle passes through the skin and is delivers stimulation apparatus under the skin, and of course is the surgical, when there's the same apparatus is inserted surgically. And what are the targets? Targets are precisely anatomical: single nerves, plexus, visceral, and a field target. Field target means that we are attacking with our electrical component, electrical instruments, small receptors, any part of the body. And another baby, the 2006 was very busy for us. We, after discovered that the external stimulation nerve locator used for regional anesthesia is performing much superior to the existing TENS device, which probably is quite familiar for all of you. We started the number of the workshop on the external stimulation. But please, if you look at the bottom of this flyer, which Kieran produced, that one of the attraction at the workshop was the coffee and Polish donuts provided. Thank you, Kieran, for including this. We did this every time for our many external neuromodulation workshops. Right, that's why we didn't stop at the time. We got it now that we felt that now is the time to create something important. To create Polish Neuromodulation Society, the chapter of the International Neuromodulation Society, and we did this. And you can see the Mr. Kieran Wazir sitting there in the Bristol Hotel, London, Bristol Hotel, not London, Warsaw. And we founded Polish Neuromodulation Society in 2011. And this was not enough. We felt that we need a large conference, and we created and organized, Andrzej, Kieran, myself, and many other colleagues, and Derek Koson was helping from the local organizing committee. Thank you, Derek. This was a memorable event, and we rented a Royal Castle in Warsaw. And this was the first ever international symposium on the peripheral neuromodulation, was the official satellite meeting to the INS World Congress in Berlin. We were able to bring absolutely top people in a world to Royal Castle there. And this was not only that it was a first Argentinian Polish Neuromodulation Society meeting, was absolutely very well attended sort of ultrasonography workshop. Was great success indeed. And we took the part of the faculty to our National Opera. They enjoyed this, and of course we entertained them as usual. And I think the memories are still strong despite the many years past.
Do you remember the opera? It was Rigoletto, if I remember well.
Rigoletto, but I have to tell you that that obviously I should include this, but we didn't. Dr. Krol, Andrzej Krol, my dear friend, he presented me with the bottle of vodka. But bottle of vodka was not the ordinary bottle of vodka, was the Kalashnikov, glass Kalashnikov with the grenades. And this was inserted in a special Red Army wooden box. And we were going for the dinner, and I received this present from Andrzej. Was very moved. I was very moved by this gift. And we were standing outside the Bristol Hotel. And suddenly, enormous amount of the police secret agents arrived because there was a president.
Japanese Prime Minister.
Japanese Prime Minister arrived for the wedding celebration. Believe me, and all this secret agents, policemen around didn't spot it. Kalashnikov in my briefcase, full of vodka and grenades, and then basically I was standing Red Star and Kalashnikov in it. That was very funny. I love it. Thank you, Andrzej. Thank you very much indeed.
So about science now, a little bit.
A bit of science. That is, we also invented the new approach to the stimulation of brachial plexus. This is just the poster presentation. Next one. This is just excellent work from Andrzej. That's can you see that over 300 patients, ultrasound, fluoro, cervical medial branch. This is just a great number of patients. 5 years collection of the data. Congratulations, Andrzej. That's a fantastic presentation. And we didn't only enjoy the Kalashnikov vodka, but we done something else. We had the 3 parts of the peripheral neuromodulation articles presented for the British Pain Society, the 3 parts of the peripheral neuromodulation. Very good job. Congratulations, Andrzej, as well to you and to
thanks for leading on it.
And this is a final point. This is just a few papers which we selected for you. These papers probably will not mean very much at the title. However, they are very important. Not only important because we are present there, but those papers representing absolutely novel approach in peripheral neuromodulation. That's simply no one did this before, and as we did. That's for this example, external neuromodulation, implantation for the angina, implantation for the brachial plexus, and so on. This is just absolutely leading top stuff from the peripheral neuromodulation angle. Now I think I have to put this to my friend Dr. Krol to say a few words about it, because that would be not appropriate maybe to talk about, because we created another thing. We created the company to produce the neuromodulation devices.
So this is going to be in production soon. So this is the baby of Teodor. It's like a crown of his on his road through pain, and hopefully this will solve our problems with pain very soon. I know some of them in neuromodulation. But just to mention to this device, there is a now trend into the peripheral neuromodulation, even for acute pain. So even when you have a surgery, instead of taking the painkillers or having the local anesthetic infusion, you may have an implanted catheter with stimulation. So this is all Teodor foreseen, and this is going this way, avoiding any pharmacological way. So good luck with this, Teodor. And I hope it will become a golden standard. So I think we are coming to an end. of our presentation. We don't know about the future. It's a map drawn in the sun, and the tide can wash it away in a moment, as we can see. So thank you, Mr. Wazir, for being with us and helping us through all these meetings. You can see there's a lot of preparation in the meeting I have, and then Teodor with Kiran with different venue. This is one at St. George's, checking the IT equipment. We lost our IT technician over the years, and so we need to manage to do it on our own. So my son Michał was always helping us with the technicalities, as also being modeling on ultrasound courses. Thank you, Michał. So we don't know where we come from there. We were hoping to meet you in person. Now we're meeting online. It's become our new normal. So we don't know where we lead and where we meet next time. Thank you very much for your attention. I think it was a bit of long lecture, but a bit of interaction. So hopefully you're still with us. And if you have any questions and comments, you're very welcome.
Okay, thank you, Andrzej. Thank you for sharing, and thank you for cooperation, and thank you, Mr. Kiran, again. And thank you, of course, to organizer, the Prezes, Dr. Bożena Laskiewicz and Tomasz, for inviting us and to giving us opportunity to present our road to pain, or road through pain.
I'd like to thank you very, very much for a fascinating lecture for both of you, and perhaps we can open for some questions. If I'll ask Tomek to help us facilitate these questions in some sort of order. Please, Tomek.
Tak, jeżeli ja też chciałbym podziękować, bo była bardzo, bardzo, bardzo fascynująca opowieść o waszej intensywnej działalności organizacyjno-naukowo-socjalno i towarzyskiej. Także to, jeżeli chodzi, to było rzeczywiście bardzo wiele dokonaliście. Jeżeli ja tak szybko rzuciłem okiem tylko na PubMed, jeśli mogę dodać od siebie, i wpisałem nazwisko Goroszeniuk, bo tak myślałem, jest dość unikalne. I na PubMedzie jest wylistowanych 36 artykułów z tym nazwiskiem. Domyślam się, że większość to jest właśnie Teodor Goroszeniuk. Nie ma za wielu osób na świecie, podejrzewam, z tym nazwiskiem. Także 36 artykułów to rzeczywiście dość duża kolekcja. A jeżeli chodzi o pytania, to bardzo proszę, można podnosić rękę, można po prostu zacząć mówić i mam nadzieję, że nie będzie zamieszania za bardzo. Jeżeli ja mogę zacząć od pytania, bo przyszło mi do głowy jedno. Mam pacjenta, który bardzo naprawdę cierpi z powodu restless leg syndrome i w tej chwili już jest na maksymalnych dawkach leków i za bardzo nie wiadomo, co przepisać. Też widzę, że pan neurolog do którego go wysyłam, za bardzo nie wie, co dalej. I czy w jego przypadku taka peryferyjna neuromodulacja, myślicie, że byłaby coś by dała i pomogła? Oczywiście nie śpi, człowiek naprawdę cierpi, starszy pan.
Tomasz, thank you for dziękuję bardzo za pytanie. Wydaje mi się, że próba tak zwanej stymulacji rdzenia kręgowego will be absolutnie wskazana. Absolutnie.
Czyli to rdzenie, nie to, co wy robicie, nie peryferyjnie, tylko rdzenia bezpośrednio.
Peryferyjnie, o co chodzi, że jeżeli peryferyjnie, to ponieważ są dwie kończyny, two legs are involved, that obviously there will be easier to reach this for the central approach, not for peripheral one. But of course, you can try that locally for stimulate the sciatic nerve, for example. To wszystko jest otwarte.
Okay.
I warto spróbować.
Super, dziękuję bardzo. A tak jeszcze drugie szybkie, czy jeżeli chodzi o wiadomo, dosyć powszechnie, chociaż nie w zachodnim świecie, popularną akupunkturę, czy ta peryferyjna modulacja, którą używacie, to stosujecie jakąś wiedzę właśnie z akupunktury, czy z akupresury, czy z tych dalekowschodnich różnych nauk? Czy to bierzecie pod uwagę? Czy?
To ja może odpowiem na to pytanie, bo to jest bardzo dobre pytanie, Tomek, bo w zależności jak my patrzymy na tą akupunkturę, czy patrzysz w kontekście właśnie tej medycyny chińskiej. Ja kiedyś mam taką grubą książkę, tą Chinese Acupuncture, i kiedyś się tym fascynowałem i widziałem takiego chińskiego profesora, który no, cuda wyprawiał z tą akupunkturą, ale to jest inna filozofia. Ta zachodnia to taka jest bardzo spłycona. Masz te punkty i tam nakłuwasz i nie dorabiasz tej filozofii, że mają być te meridiany połączone i ta yin-yang energia ma gdzieś tam się równoważyć. I ja wierzę, że to jest skuteczne. To trochę tak jak jest jak medytacja w tym podejściu. Ale nie będziesz leczył na przykład ropnia czy zapalenia płuc taką akupunkturą, tylko właśnie te zaburzenia energetyczne i osiągnięcia poziomu równowagi. Także kiedyś w NHS-ie to myśmy mieli pielęgniarkę, która właśnie tą akupunkturę stosowaliśmy, ale później to NICE to odrzucił i zdyskwalifikował. Teraz troszeczkę jest powrót do tego, czyli jako NHS nie jesteśmy w stanie tego zaoferować, ale jeżeli pacjent mnie pyta, to ja mówię zawsze jak najbardziej proszę spróbować, bo niektórzy będą temu, jak to się mówi, będą odpowiadać na to leczenie i inni nie. I to też w zależności od, tak jak przedstawiłem na tym pierwszym slajdzie, w zależności od kondycji, jaką masz. No jeżeli masz ucisk na jeden nerw kulszowy, to może tu akupunktura nie zadziała, ale jeżeli cierpisz na ból, jakby to nazywany chronic widespread pain, czy fibromialgia, to jak najbardziej taka akupunktura będzie wskazana.
Ja nie bardzo zgodzę się z tym, bo ja uważam, że nawet przy innych schorzeniach Chińczycy akupunkturą leczą wszystko, nawet i zapalenie płuc. Ja zrobiłam kursy akupunktury i ja na początku byłam bardzo negatywna co do tego. Uważałam nawet, że przynoszą nam fałszywych pacjentów. Z tym, że patrząc na jak pacjenci są operowani tylko i wyłącznie przy akupunkturze i nie mają żadnego bólu, to tylko Chińczycy mogą zrobić i to jest ich tajemnica właśnie, jak ty mówisz, że oni stosują ten swój stary styl myślenia o meridianach i połączeniach i oni tej wiedzy nas niestety nie przekazują.
Absolutnie się zgadzam.
Można zapytać pytanie?
Jasne.
Więc główną raka, co leczę, to jest raka opłucnego i czasami wysyłamy pacjentów na kudotomii. Więc chciałem wiedzieć opinię na temat kudotomii. Teraz niedawno była publikacja na temat kudotomii experience w Anglii. Okazuje się, że to jest dość późny referral, że pacjenci dostają ten intervention przy samym końcu już i przeciętna żywotność jest około miesiąc po tym, więc chciałem wiedzieć opinię na ten temat z Państwa strony. I też drugie pytanie jest na temat cadavers. Jak to wpływa na uczenie? Czy to jest bardzo konieczne? Jaka to jest perspektywa na temat cadavers w uczeniu interventions? Dziękuję.
Teodor, czy ja mam zacząć, czy ty?
No to zacznij, tak, oczywiście. Tak.
Jeżeli chodzi o chordotomię i te interwencje w zaawansowanych nowotworach, to jest rzeczywiście problem teraz chyba taki tutaj na całym świecie, bo rozwinęła się ta medycyna paliatywna, w której no, ja też brałem udział, mamy dostęp do tej farmakologii i proszę pamiętać, że pierwsze tutaj Pain Society w UK to było Intractable Pain Society. To byli anestezjolodzy entuzjaści, którzy właśnie wykonywali różne tego typu zabiegi. Ja zaczynałem, tak jak pokazywałem, od splotu trzewnego, blokady w nowotworach z bardzo dobrymi efektami. I tutaj w St. George's my rzadko mamy jakieś ostatnio pacjenci, żeby byli referowani, albo są, jeżeli są przekazani, to są bardzo późno, kiedy już te zabiegi nie są skuteczne. I podobnie będzie z tą mezoteliomą. Nie wiem, czy Joe Zopardy jeszcze jest z nami, bo on się w tym specjalizował, jeździł do Portsmouth, do doktora Pondera, uczyć się tej kordotomii. Myślę, że w UCL tam jeszcze jacyś koledzy robią, ale ten zabieg jest tak rzadki, no bo jest ryzykowny. I teraz znalezienie tego, ja to nazywam tego okna terapeutycznego, kiedy ta interwencja jeszcze może pomóc, i poprawi komfort życia, a kiedy jest już za późno, kiedy już ono nic nie zmieni, to jest bardzo trudno w tym systemie naszym trafić. Ale jak najbardziej mezotelioma i jest to przy trudnym opanowaniu bólu, to jak najbardziej wskazanie jest to kordotomii. I na twoje drugie pytanie odpowiem, jeżeli chodzi o kadawery. Tak, ja słyszałem takie głosy, mówią, po co w ogóle jest anatomia? My możemy teraz wszystkiego online się uczyć i już niepotrzebne są te wszystkie anatomiczne preparaty. No i z tym się nie zgadzam, bo nic nie zastąpi i ta anatomia to jest taka, jesteśmy tak skomplikowani i to, co uczymy się na studiach, to są jakieś tam po powierzchni przechodzimy, tylko później gdzieś tam specjalizujemy się w jakiejś gałęzi medycyny i też ta anatomia jest ograniczona. No ten ultrasonograf to otworzył tą anatomię i teraz połączenie tego, to co jak człowiek jest zbudowany i do tych wszystkich struktur, to my się dowiadujemy więcej, jak można leczyć, jak można pomóc, jak można być bardziej precyzyjnym. No i żeby nie zrobić krzywdy, to no nie ma takich fantomów, takiej jakości, żeby można było odtworzyć te struktury anatomiczne i jeszcze nauczyć się, żeby wykonać ten zabieg precyzyjnie i bezpiecznie. Także te warsztaty kadawerowe, no zawsze dziękujemy rodzinom tych, którzy no, poświęcili i swoje ciała na to, żebyśmy mogli się edukować.
Dziękuję bardzo.
Pragnę jeszcze dodać, że my zaczęliśmy anatomię w oddziale anatomicznym w Białymstoku i używaliśmy wtedy tak zwane kadawery, eksponaty stare. To było dosyć ciężko i dzięki mogliśmy się przesunąć później do tak zwanej medycyny sądowej. To dzięki Piotrowi Buczkowskiemu, Darkowi Kosonowi w Gdańsku i Warszawie. Także jest to zupełnie jak praktycznie świeże ciała. No niestety tak możemy powiedzieć, jest to znakomite doświadczenie anatomiczne i nauka na tak zwanych forensic medicine czy medycyny sądowej eksponatach jest nieporównywalna z niczym.
Nie słychać ciebie, Paweł, nie słychać ciebie.
Wyłączone ma
tak,
głośno.
Mikrofon jest wyłączony chyba, bo...
Przepraszam, mam wyłączony. Chciałam zapytać o cannabis i jaka jest wasza opinia. Bardzo kontrowersyjny temat, jeżeli chodzi o leczenie bólu, a dużo się o tym ostatnio mówi w mediach, więc chciałabym usłyszeć waszą opinię na temat cannabis.
Ja się wycofuję, Andrzej.
No opinia jest taka, że tak, rzeczywiście mamy teraz pacjentów, którzy przychodzą i w zasadzie domagają się, żeby im przepisać cannabis w różnej postaci. No i tak jak powiedziałem, tam do tego slajdu o tym skomplikowaniu bólu. Teraz opioidy są złe, zabijają ludzi i teraz otwieramy fabryki i przychodnie cannabis i będziemy sprzedawać je. No ktoś robi na tym pieniądze. W 1888 roku to już stosowano. Jeżeli ktoś ma i chce stosować, jak najbardziej, jeżeli chodzi o oficjalne stanowisko Faculty of Pain Medicine, to nie ma dowodów na to, żeby to stosować w bólu. To jest w ciężkiej epilepsji, w tej chwili u dzieci w spastyczności, w stwardnieniu rozsianym. Natomiast jako w leczeniu bólu, no to tych ewidencji nie ma i my no nie przepisujemy i nie ma takich dyrektyw. Jeżeli ktoś chce sobie tam ten CBD-OL kupić i twierdzi, że mu pomaga, no to jak najbardziej. Ja jako taki skrajny przykład podam, że widzę czasami młodych pacjentów, którzy nadużywają tych kannabis w postaci tej marihuany i palą i mają totalnie disinhibition, brain disinhibition. To są zachowania na granicy psychotycznej i teraz możesz dyskutować, że to jest THC, to właśnie trochę psychotycznie, CBD to tak łagodnie, a teraz nikt nie wie, jakie te proporcje powinny być. No ale receptory w naszym ciele są, czyli widocznie i ta substancja używana była od tysiącleci, więc jakąś tam rolę odgrywa. Natomiast no, na pewno nie jest to panaceum.
Dziękuję. Tak myślałam właśnie. Może więcej potrzeba badań w tym kierunku. Niemniej mamy opioidy, morfiny, które od lat są skuteczne i no, chyba nie jest to prawdą, że zabijają ludzi, jak są używane umiejętnie i w odpowiednich dawkach.
Nie, no chodzi o to, że nastąpiła ta troszeczkę pomyłka, że w nowotworze oczywiście jest ból jest tym szóstym objawem życia i trzeba go leczyć, jeżeli jest w jakimś stanie nowotworowym skrajnym, terminalnym. Natomiast w bólu przewlekłym, gdzie spodziewa się, że ten ból nie ustąpi, używanie tych opioidów przez dłuższy okres przynosi więcej szkody z punktu widzenia i hormonalnego, i immunologicznego, i zachowania ludzi również. Także to jest to i nadużywania, tak jak to było w Stanach. My takiej sytuacji tutaj w UK żeśmy nie obserwowali, że jakby tej opioid epidemii, to jest właśnie w Ameryce to było promowane i pamiętacie doktora House'a, on to przyjmował, łykał ten oksykodon, a szczególnie oksykodon jest tym niebezpiecznym lekarstwem, bo on powoduje silne uzależnienie i stąd to się wszystko zaczęło. To jest podobnie jak dolantyna, dolargan, jak pamiętacie w latach 70. ma silne działanie uzależniające i ludzie, którzy zaczęli to przyjmować, nie jesteś w stanie ich od tego odzwyczaić. I w Niemczech, przepraszam, żeby za długo nie mówić, w latach 70. tych oksykodon już był odkryty, ale stwierdzono, że ma duże działanie uzależniające i tej produkcji nie wdrożono. A w Ameryce po 30 latach tam FDA, ta kompania to obeszła i to wprowadziła i stąd mamy taki rezultat. Także wszędzie gdzieś ta równowaga jest potrzebna.
No ja muszę powiedzieć, że oksykodon jest powszechnie przepisywanym lekiem, tak jak ja jako GP praktykujący przepisuję z tego sporo.
No, a ja ci powiem, że jak my w poradni bólu praktycznie w ogóle nie przepisujemy opioidów, a raczej co robimy, to staramy się, żeby pacjenci odzwyczajać ich od przyjmowania opioidów, bo ktoś tam z nimi zaczął te opioidy i my nie widzimy wskazań i próbujemy ich odzwyczajać. Nawet nasza koleżanka prowadzi w St. Thomas' Opioid Reduction Clinic, bo to jest ta grupa chorych, którzy nie mają już korzyści z tych opioidów, a czują one większą szkodę. Także my się zajmujemy tymi blokadkami i neuromodulacją z Teodorem.
Jeśli można się dołączyć do tej dyskusji.
O, witaj Piotruś.
To bardzo mi miło, że jestem tutaj pierwszy raz. Mam nadzieję, że będę częściej, ale z tej krótkiej wymiany zdań już widzę, że żyjemy w trochę innych bańkach informacyjnych, prawda? Andrzej nawet nie zauważył, że jest epidemia uzależnienia od leków wypisywanych na receptę w tym kraju, czy w Zjednoczonym Królestwie. No, ale nie wiem, czy lekarze rodzinni będą wiedzieć, że NHS England ma specjalny program właśnie skłaniający ich do tego, żeby tych leków nie przepisywać w bólu przewlekłym i są właśnie tworzone te kliniki dla chorych, których trzeba jakoś odstawić od tych leków. No, a problem jest tylko taki, że jeżeli zapomnimy o interwencjach, to nie ma nic w zamian. W związku z tym jest to praktycznie mission impossible. Chciałem jeszcze takie pytanie porządkowe zadać, bo zauważyłem, że na początku było sporo kolegów anglojęzycznych. Joseph Azopardi pewnie by powiedział coś na temat kordotomii, ale on chyba nie bardzo rozumie naszą dyskusję po polsku, więc tak techniczne pytanie, czy my rozumiem, że dyskusja normalnie po polsku się toczy, tak?
W obu językach, jak komu wygodnie.
Dziękuję.
Czy ja mogę spytać naszych mówców właśnie? Mam koleżankę, która dostała takie acute torticollis i ją leczą już parę lat i podnoszą dawki gabapentyny i coraz więcej, coraz więcej. Czy dla niej jest jakieś właśnie wyjście z tego?
Czy jest skierowana do kliniki bólu przede wszystkim? Pierwsze pytanie.
Właśnie raczej do jakichś ortopedów, zdaje się.
No nie,
Coś
no
i tam mówią.
to jest pomyłka. Powinna być skierowana do lokalnej kliniki bólu.
Tak.
Czyli to jest Londyn, czy to jest poza Londynem? Czy...
Nie, ona jest z północnego Londynu.
No to przecież jest taki wybór, że...
Gdzie robią to, co wy robicie?
No to są różne specjalności w różnych oddziałach, ale generalnie pierwsza referral powinno być do lokalnej kliniki i tam wtedy lekarz by wybrał najlepszą drogę, gdzie później zreferować. Tak to widzę. Andrzej, pewnie zgadzasz się, czy...
Tak, oczywiście. No, bo to...
Nie może prosić o to, żeby to St. George's ją do was tam.
No może, jeżeli GP skieruje, to jak najbardziej, bo nie ma rejonizacji, także może być skierowana i w zależności od tego, jaką przyczynę tam jest napięcie tych mięśni, czym spowodowane, można to jakoś tam spróbować uwolnić.
Dziękuję.
Dorota, masz mikrofon wyłączony.
Koniec świata z tymi mikrofonami. No.
Przepraszam, jak długo się czeka na wizytę? Bo ja wiem, że lokalnie u nas tutaj w Kingston w szpitalu to mamy strasznie długie okresy oczekiwania, żeby się dostać i to już nawet nie teraz, jak jest pandemia, ale sprzed pandemii długo się czeka, nie wiem. I też ci pacjenci są zreferowani, zwykle parę wizyt i są wtedy wypisywani z tych klinik z powrotem pod opiekę lekarza rodzinnego.
No teraz w tej pandemii to troszeczkę wszystko jest na głowie, ale chyba nie jest jakoś tak tragicznie u nas do St. George's, jeżeli chodzi o ten system referowania. No nie powiem ci tam, czy to jest 2 miesiące, czy 3 miesiące, to jest gdzieś tam koło mniej więcej ten okres, bo to jest poza naszą kontrolą, bo to idzie do tych central bookings i ten triage, no także my tego w ogóle nie jesteśmy w stanie kontrolować. Natomiast jak już pacjent jest, no to wtedy to już w miarę szybko się odbywa, jeżeli nawet chodzi o te zabiegi, jeżeli są wskazane, to też nie jest jakaś lista oczekująca. Czasami jest tak, Dorotka, że po prostu dobrze tego pacjenta, wiesz, zreferować to do pain clinic i tą opinię otrzymać, ale w tych bólu czasami jest tak, że my nie mamy tych prostych rozwiązań, bo to i ci pacjenci, owszem, no może jest tak zwany ten pain management program, ten wsparcie psychologiczne, bo są sytuacje takie, że my możemy pomóc i to najwspanialsi pacjenci to są starsi ludzie z jakimś tam zwyrodnieniem shoulder, hip, knee, bo my te zabiegi wykonujemy, czy gdzieś tam trapped nerve. To są takie rzeczy, które są bardzo efektywne i pomagają. Natomiast no, u kogoś z bólem takim, jak to się mówi, chronic widespread pain, chronic fatigue syndrome i to immunologią, to my nie jesteśmy w stanie im pomóc poza dobrym słowem, no tak można powiedzieć.
Andrzej, ja wiem, bo ci pacjenci do nas też przychodzą bardzo często, to są trudni pacjenci, którzy wymagają dużo czasu od nas i przypuszczam, że u was też oni są dosyć trudnymi pacjentami do prowadzenia. Jest takich pacjentów dosyć sporo, nie da się ukryć.
Niestety tak, tym bardziej, że sytuacja życiowa też wielokrotnie nie pomaga. To się nazywa, jak to mówię, cramped life syndrome.
To nie słyszałam takiego określenia.
Także jest coś takiego. No, także,
cramped syndrome, okej.
No, także na to niestety nie mamy odpowiedzi. Piotruś, jakiś komentarz do naszego wykładu?
No, ten cramped life syndrome to jest oficjalny, są nawet publikacje naukowe
tak?
na ten temat. Następnym razem może omówimy to bardziej szczegółowo, bo to się
może Piotr byś nam wypowiedział.
Natomiast mój komentarz to chciałbym dorzucić taki, że bardzo ciężko jest wymyśleć jakiś sensowny program dla tych pacjentów bez postawienia diagnozy. Niestety nie można tego zrobić na podstawie właśnie na przykład takiej konwersacji, jak w tej chwili tutaj odbywamy, albo na podstawie jakiegoś tam zdjęcia Trzeba tych chorych po prostu dokładnie zbadać, poświęcić trochę czasu. W primary care lekarze pierwszego kontaktu mają straszne warunki. Właściwie nie ma możliwości pogadać z pacjentem, nie ma czasu, żeby ich zbadać. No, jak nie ma diagnozy, to nie ma efektywnego leczenia. Mój komentarz jest taki, że w mojej praktyce mam bardzo dużo pacjentów, którzy po prostu odbijają się od różnych instytucji przez lata bez postawienia diagnozy albo ze złą diagnozą. I właściwie wszystkie moje sukcesy kliniczne opierają się na tym, że tą diagnozę stawiam i leczę tych chorych. No i innego mechanizmu nie ma po prostu.
Tak.
So, Joe, are you hearing? There was a question about the cordotomy. Would you like to comment about this? There was one of the colleagues in Polish. He was asking about the cordotomy.
For lung cancer.
Maybe if I ask the question in English, then.
Yes,
that would help.
I didn't realise you
That would help.
were on the call. So basically, I mean, I have quite a large patient population with mesothelioma.
Yep.
And, you know, it's very rare, I have to admit myself, that I refer patients for cordotomy. It's often somebody else suggests it. And actually, there was a publication just at the end of last year, I think BMJ Open, showing from, I think, Manchester, from Scotland and Portsmouth, that referrals are often late. They're around 13 months into the diagnosis, and the median survival generally is around 12 to 18 months. And there's only 1 month survival benefit. You know, the patients only survive 1 month after the cordotomy. So I was just wondering what your experience is if you're doing these procedures. Does that tie in with that? And would you know, what's the way of getting these patients to you sooner?
Well, we're very dependent. First of all, to answer the question, I mean, we're very dependent on referrals from the oncologist and the palliative care team. And you're right, they're very late. And in part, that's, I think, a lack of education, a lack of information given to our colleagues who refer. We're not doing them at the moment in St. Thomas's, and so we are referring to Portsmouth, which is our closest center right now.
And why are you not doing them in St. Thomas's? Is it?
Well, it's an organizational thing. In order to do these procedures, you need to have the setup, and our clinic isn't geared up at the moment to do it. We're hoping to start very shortly, but I think there has to be a recognition that this procedure is a complex one, and it doesn't sit in isolation. It has to be part of an MDT, and that is being built up slowly. So I think the centers where we are referring to at the moment, Portsmouth, have been doing them for many years. There's also Liverpool as well, and that, I have to say, perhaps falls as it can be described as the ideal setup, because they have weekly MDTs jointly with palliative care. We at the moment have a virtual one, and we're hoping to extend that to a weekly presence together. Now, the problem, I believe, is that these patients are being referred late, and unless they're able to lie still and in the supine position for at least an hour for the procedure, they're not in a position to have this. Our arrangement has always been with palliative care that they refer early, we discuss, because not every patient who's referred actually wants to have this invasive procedure. So we have an information package which is made available in e-format as well as leaflets, and we have been giving it to our oncology colleagues so they can at least have that preliminary discussion with the patients that there is something that can be done. Most of the time, patients who are in the early stage of their diagnosis are declining the procedure.
Okay. And so the two main areas in the UK are Portsmouth and Liverpool.
Portsmouth, where there was Oldham that is no longer offering it. I know that there was a clinician up in Scotland who was interested, but I don't believe he is offering it. And if you go onto the Mesothelioma UK website, there are the centers that are offering it with the key numbers. I'm hoping that there will be a provision for this in London. I know there's a neurosurgeon in Queen Square that offers open, but given that these patients are being referred so late, I very much doubt that they will be well enough to have this kind of surgery. Now, there's also a neurosurgeon in George's who is interested in cingulotomy and has done a number of cases for refractory.
Erlich, you mean Erlich Pereira?
Yeah, Eric. So he's a good colleague of ours, and he has spoken on a number of our meetings and presented with this. But I still think there is a role for chordotomy. There's also the cohort of patients with brachial plexopathy that are often referred late, and they may also benefit from this procedure. And we've had patients also who we referred and had successful chordotomy for pelvic tumors. So they've had a stage chordotomy and they did well. So there is a role for this, for sure.
So currently nobody in London is offering it either in the NHS or privately.
No. And I certainly wouldn't advocate this procedure to be done privately. Okay. But again, talking about cancer intervention provision, there's no one offering pumps also in the private sector. But UCH is offering intrathecal drug delivery systems for cancer in a limited way, and also King's has that provision. So I think the provision is patchy. The faculty just before the first lockdown of the pandemic had set up a protocol to set up looking at the framework for delivery of cancer services across the country, and they invited centers to participate as a pilot site. St. Thomas's was a successful site, and so we're waiting eagerly to start participating in this, but everything has been put back, and it's been pushed back twice now. But it doesn't stop individual centers from trying to set up their clinics to become participants. I'm sure that they will be calling out for new centers. And so if there's anyone that's interested in participating this way, I think they will be welcome to partake in this.
I mean, from this paper, which was, as I said, just published in December last year by Pullman and colleagues in BMJ Support Palliative Care, the adverse event rate's quite low. It's only was 4%. So, which I didn't realize. I thought there was higher. So there must be a reason why patients are being put off the idea earlier on. But maybe the pharmacology is working, and maybe that's
you may say that. I think I remember Derek Pounder, who taught me initially how to do these. He always quoted that there was a mortality of less than 1%, and I mean their series was ranging in about 800 by the time he retired. And so I've never seen any major adverse events. I have seen incontinence that resolved within a week, but in the main, it is a safe procedure in good hands. And Manu up in Liverpool will also attest to this, that it's a safe procedure. But it doesn't always work. We always tell patients that you're looking at about 70 to 80% success rate, but it has a good track record. It's been around for quite some time now.
And there's no role for electrical neuromodulation in mesothelioma type pain. You really have to do nerve destruction.
I don't think there is, no. I think if looking in the cancer population at large, with the increasing number of cancer survivors, yes, there is a role for neuromodulation. That is for sure. And we're seeing this particularly in the post-surgical pain syndromes. We're seeing a large number of patients post-thoracotomy, even the robotic-assisted and VATS procedures having persistent chest wall pain. And these are, if they survive the surgery and they're given a good outcome, then yes, they're a candidate. The other interesting group is the chemotherapy-induced neuropathy patients. Again, a massive number of these patients are in the system and they are not benefiting from pharmacotherapy. And so, yes, there is a role in the cancer group at large. But specifically for mesothelioma, I fear it's not the way forward.
Okay, that's great. Thank you very much.
You're welcome. Thank you.
There are two questions from Dr. James Blunt, I understand, on the chat. Would like to ask them, unmute yourself and ask, James. Okay, no response. And there's a question from Dr. Shepielov on the chat. Oh, yes. Would you mind introduce yourself and please ask the questions?
Certainly. It's lovely to see Dr. Goroszeniuk and Andrzej Krol and Dr. Leban. My name is James. I'm one of the anaesthetists in this Polish society. And I just wanted to ask the question whether, given the fact the society has a subspecialization in neuromodulation, especially in chronic pain, whether we have advanced more with respect to acute pain. We know that some of our American colleagues presented the use of neuromodulation using electrical catheters inserted by ultrasound guidance for total knee replacements in the last ESRA meeting. And I was wondering whether we've had any progress with respect to this in either the UK or Poland.
Yeah, you want to start or?
There's simply, I don't want to advertise this, but our company Remedius is working on this particular site, and we have developed a special catheter to be used in acute medicine. That's what I can say. Has not been approved by CMARC as yet, but going to be done during the next few months.
So James, it's a very good question. You remember at the end of the presentation, I presented this paper, I think from Brian Seitz, his group, and showed the Remedius device as well. So I'm aware of this perspective. So it's not only chronic pain, but acute pain. And with ultrasound, as you introduce the local anesthetic catheter, you can easily introduce the catheter and deliver, instead of the infusion of local anesthetics, it will in electric current. So I think it's all the early stages, because I think the price, and there's no commercial material to use it. So this is all the trials. But I think this will be the future. And then just give you the one example. That's many years ago when Theo started the thinking about this field, peripheral neuromodulation, catheters. There was only nerve stimulator to localize. And also there is a long line, you need to put this IPG somewhere. So that was very bulky. So now we have this, at least two companies, Steam Waves and another one, when they produce these wireless devices. And then we tested it to use ultrasound to insert it. So there's no wire attached, not IPG, you got just external device over the catheter. And this is the future. So that's what we were talking about 10, 15 years ago. Actually, it is happening. So you just need to watch the space. And I think this will be especially, my special interest is the post-amputee pain. And we're doing the service at St. George's with the catheters with local anesthetics. And there's a lot of logistic, as you can imagine, for using this. So this group of patients will be the best one to have this implanted catheter, because you run the infusion for 2, 3 days, 4 days, 5 days, but they can be sent home with this, and then you can maybe see the less of the phantom limb pain or the stump pain. So this is the future for sure.
Thank you very much. I just have one more question, if I may.
Of course.
Can I ask you if and what facilities there are for palliative care patients who have pain, for instance, from inoperable breast cancer in Poland, in order to reduce opiate intake and improve well-being and awareness?
So what options are available in Poland at the moment?
Yes, what interventional pain techniques. So one would think of potentially perhaps subcutaneous long-term PEX1-2 block catheter for breast cancer, but that's not really practical because it's a long-term infusion, has an infection risk.
Yeah,
but of course
absolutely.
you would reduce the opiate intake and make the patient a bit more awake and less nauseous. However, that is a plane technique. It relies on the local anesthetic going along the plane. An alternative might be a paravertebral intervention, but that might have more teeth with it if you're using electrical modulation, perhaps. I'm just wondering if there are any facilities in Poland that, for instance, in Słupsk, as you have a center there, are there any other centers that would be able to facilitate this? It's just that I have someone who I know there who has this particular problem.
So if you just contact me and on me and Theo personally, I think not sure if Darek Koson is still and Marcin Kowat from Warsaw are still on the line, but we know all these interventionalists because we trained them for the last 15 years. So there's a center in Mońki by Wojtek Nierodziński. He runs the center. There is in Bielsko-Biała, there is a Grzesiek Hura who's running the pain service. We have the very active group somewhere in Silesia, in Tychy. So we have these facilities. With a cancer pain, it may be tricky, as you have said, to provide a catheter or paravertebral or epidural. Neuromodulation techniques, I agree with Joe, with the cancer pain, it may be not enough. You need some neurodestructive procedure. But it's worth to discuss. So if you just contact me personally, I will direct you to the right place. And I'm in this clinic in Słupsk for once a month, roughly. But my colleague Dr. But is there twice a week and running efficient service. And now Piotr also is opening the center in Gdańsk soon. Instytut Medycyny Bólu, if Piotr is with us. So yeah, feel free to refer.
Thank you very much.
So Tomek, are we exhausted?
Jest jeszcze jedno pytanie na czacie. Przede wszystkim na czacie jest bardzo dużo pochwał was i bardzo dużo podziękowań. Ja wam wyślę potem ten czat, żebyście mogli poczytać, bo bardzo się podobało wasze wystąpienie. Jest jeszcze pytanie od doktora Szepielowa. Jaką widzicie różnicę między swoją neuromodulacją a TENS?
Teodor.
What I need to say that with many years ago, and we had a patients with TENS, and this was just absolutely well-established neuromodulation technique. And suddenly that I discovered by applying the probe, a probe of the nerve locator to the neuropathic pain patients, and suddenly that completely pain has gone. This was probably 20 years ago. And later came that, for example, 90% or 95% patients had any success with TENS, but they responded to the so-called, what we call the external stimulation. And just briefly, the reason might be that TENS electrode is just a large surface electrode. There is not enough power to penetrate the skin or to reach the target. If you have the 10 millimeters probe, whatever is created from, that basically this penetration is much deeper and much more successful. This is probably success from the external stim and difference between the TENS and the X stim which we are using. Is this sort of a fair explanation, or shall we go anything deeper? Or?
No, we will not know because Dr. Shepielov is off sound.
Okay, fine. This is my explanation.
It's very good
size of the electrode, penetration, reaching the target, nerve, plexus, or the receptors.
Excellent, thank you.
Tomek, are there any more questions?
I think that's it. We can start finishing. Yes.
Thank you ever so much. Once again, thank you ever so much to both our speakers and also to Kieran for facilitating this. It's been a very fascinating morning, and thank you, Tomek, for organizing all the IT side of things for us. As usual, very efficient, and it all worked well. So, and I would like to thank all of you for attending, because there were about 33 people at one stage, which is very good. Our next 3 lectures will also be online, and you've been given the dates in the invitation, which we sent out together with this lecture. And so we've got a very, very rich program of lectures from absolutely top authorities. So I'm very pleased about that. And so once again, thank you very much to everyone. And hopefully we'll meet next month. It's a Friday evening next month. And for a very topical lecture. So thank you, and see you all in a month's time, hopefully.
Thank you and have a good Sunday.
Thank you.
Tylko dodam, wszystko było nagrywane i będzie dostępne na naszej stronie Polskiego Związku Medycznego. Zawsze można wrócić i obejrzeć.
Tomku, tylko pamiętaj dodać nas do tej listy, bo jak mówiłem,
tak, to tak? Na 100%.
No,
tak,
dobra,
tak.
No, dziękujemy, to był fan.
Dobrego.
Mam nadzieję, że się podobało.
Dziękujemy bardzo.
Thank you,
Ja jeszcze chcę coś powiedzieć, czy mnie słychać?
Darek, tak?
Ja, mówiąc polski, ja chciałem serdecznie podziękować kolegom z Anglii, którzy są dla nas nauczycielami, na których zawsze możemy liczyć. Kiedy ta współpraca od kilku lat układa się fantastycznie i mam nadzieję, że lista ośrodków takich praktycznych, które będą leczyły ból w Polsce, będzie wzrastała. Mam nadzieję, że ta epidemia nie przeszkodzi nam w kontynuacji nauki, w organizacji kursów i serdecznie zapraszamy do Polski.
Super,
dziękujemy, Darku.
Dziękujemy.
Dziękujemy bardzo.
Dziękujemy.
Dziękujemy, Darek.
Do widzenia. Udanej niedzieli wszystkim życzymy.
No, do widzenia, hej, hej, cześć. Dzięki wszystkim. Dzięki, Tomek.